Yes, the class will be till 9:30 today. It is a 2 hour session that we have to take the time off and okay. Are the notes enough for the next exam? Okay, they are more than sufficient because in notes we have got a good amount of content that is actually being asked in all the exams, not only the next exam. With the help of notes, you can easily prepare for any length of the exam across the country. Okay. Class will be till 9:30. Don't ask again and again. Yeah, a part of Ramayana you will miss. I agree. But there's always a repeat telecast, no? The morning session, you can obviously see that. And nowadays, we are somewhere on the Uttar Ramayana episode. My son watches Ramayana very regularly. He's become a very religious person. And in this lockdown, I think so, I have become a Sanjeev Kapoor in my house who's cooking food all the time. Right. Now, which books to read for the profs? That's a very genuine question. If you are targeting your exams, which are the university exam, so I'll tell you one thing, need not go to Harrison for that. At your end, you can buy a simple book like Matthew and for clinical practice Kundu, and you will be able to get a good rank and a score in the university exam for profs. But when it comes on to the actual entrance exam, please, there is none other than Harrison which will help you. So I would suggest that don't waste time here and there in too many books. But how to approach Harrison reading, as Arvind sir also keeps on telling this, uh, you should always have an idea of what you are going to read in Harrison. Best way I always feel is to read our notes first, then go to Harrison and see what's given over there and what is relevant and what is irrelevant. Because a lot of things are there in Harrison which is not really relevant for the exam. Okay. Okay. For pregnancy, which drug is safe for migraine? Okay, I was discussing with Dr. Ankit also in the morning about this. See, I'll tell you one thing. Yesterday, I was clear on the thought that in pregnancy, the severity of migraine and the number of attacks are going to decrease. One thing. Now, in pregnancy, if a migraine patient comes to me, and of course, they are not on the prophylaxis because all those drugs that we mentioned for prophylaxis can have an effect on the fetus intrauterine. So, what to do next? You can try out a simple analgesic, which is a paracetamol, firstly. And if the patient doesn't respond, then you have to give a triptan. So there is this concept, what drug in pregnancy is safe and all these are old concepts. See, I'll tell you one thing. You're not giving triptan on daily basis. You're giving it one or twice, and it's not going to affect the fetus so bad. You require a prolonged exposure of any drug to cause a teratogenic effect now. So you can give this thing in a half dose or could be a lesser amount of dose, right? Okay, some students have got another genuine doubt. Basilar, hemiplegic migraine, retinal migraine. Oh my God, there are many migraines actually. Other types apart from the classical and the common that we discussed yesterday, and of course that acephalgic. Uh, what I feel is that I'll discuss it. I'll discuss all those kinds of migraine in a separate box. Okay, I'll put the on the Facebook club some post or I'll discuss in this lecture. Okay, if I get a time. Davidson, yeah, Davidson is like Chetan Bhagat, and Harrison is like I think so Shashi Tharoor. Reading Harrison is very difficult. I'll show you some lines later on of Harrison which are really more confusing than anything else. Okay. Harrison is a gold standard book, no doubt. I'm not making fun of Harrison, but you should always realize this fact that Davidson is not going to really help you out for clearing an entrance kind of an exam. Okay. CMDT is fine, okay, but I think so. CMDT is not enough a book to gather too much of knowledge, okay? Because I feel till date that CMDT is like Google, it gives you more information than knowledge. So if you are thorough with any other book, then you go to CMDT, that will be fine. Okay, One joke, please. Don't worry, I'll crack many jokes today. You're attending some live comedy session or what? See, humor is good actually. It helps you to stay active. See, if you are laughing on a joke, it's fine. If you're not hearing a joke and still laughing, then you require to see some doctor. You know, laughter is the best medicine. But if you are laughing without any reason, you require medicine. That's the saying. There is no role of potassium as such in seizure disorder. I was very clear in that thought that sodium affects the heart. Sorry, sodium doesn't affect the heart, and the potassium doesn't directly affect the brain. Okay. Okay, one doubt, genuine doubt from the yesterday's class is that, sir, what are the uh, drugs which are, what is the relation of trigeminal in the trigeminal autonomic cephalgia? See, the thing is this, that it is cephalgia, it's head pain, and it's a trigeminal nerve activation also. As I was telling you yesterday that the anterior and the middle cranial fossa will always gather any sensory input from the fifth nerve. Now look at the concept. There is a fifth nerve activation causing a lot of headache. One thing. Secondly, in the patient there are autonomic symptoms also seen with them. So that's a very important concept, that it's not only a fifth nerve, it's also an autonomic kind of a thing that happens. Okay. As you remember in all these cluster headache and all these kind of things, that in the patient we had a lot of autonomic stimulation, especially parasympathetic, which can be lacrimation or rhinorrhea. Okay, first students wants to ask like how should I approach medicine? I think so. You should go back and see the YouTube video which Dr. Arvind and Sumesh sir had put up on the YouTube channel. Just go through it once and don't take too much headache in medicine. Okay, and remember, the medicine is something, if you read, you'll be able to understand a lot of other disorders also. But at your level, as I clearly said, for profs, it's not too much of headache. But how for the entrance exam, of course, you have to go to the notes first and then go to the Harrison ones. The doubts are coming in, coming in. Some doubt. Okay, Midas score. Okay, I just forgot to mention it yesterday. Midas is a scoring system that we apply for migraine. I'll just tell you separately, don't worry. Some here and there points we do miss in our classes, but it's good that you guys are catching me. I'll tell everything, don't worry. Nothing will be left untaught in the class. Yeah, trigeminal autonomic cephalgia as such, they don't have a clear reason. One reason for cluster was a precipitating alcohol, but that's why the cluster headache or any other brother of his is always coming under the headache of under the heading of the primary headache. Okay. How is Kumar and Clark? Yeah, I used to read in my college days that book because that was the book which was available in the library. But later on, I found really it's not going to help me too much. See, there are so many medicine books, not only Kumar and Clark, there can be more than that. But I suggest you, if you want to clear the profs, it's fine. You can go to Matthews and read it once. It's more than sufficient. You'll get good marks. And of course, if you attend the theory paper, you know nothing, you're not scared of. But there's always a person in your class, who gets up after half an hour of the starting of the exam and asks for what? Extra sheet. So be careful of these kind of people. And Harrison, yeah, Harrison is no doubt a gold standard. Don't try to avoid Harrison every time. Okay. Okay. Pseudotumor cerebri, any investigation, as I told you yesterday also while discussing the MCQ, pseudotumor cerebri is a diagnosis of exclusion. That means a patient comes with headache, a sign of a raised ICT papilledema with no focal deficit. And on top of it, the CT scan is something which is found to be normal to them. Okay. Practical books for medicine, there are many. Hutchinson, yeah, gold standard, no doubt. I still read Hutchinson a lot. But at the end of the day, you have to answer some kind of questions also to the examiner. I think so. Kundu will be a good book to answer any kind of question. Okay. Right. Now we are on time. Let's start the class. And happy Ramzan. Yeah, we started the class with late half an hour because some people have to break the fast or do the iftar. And when your friend invites you for the iftar party, like my friends do invite me, uh, I always think that their image has really increased in my heart for them. Okay. Okay. So happy iftar. I can also have something, sweet dish or something. Fine. Right. Just a second. Right. Let's start the class today. Today's topic, as I told you, is going to be myasthenia gravis. Myasthenia gravis. Right. Now, today's topic that we have with us is a neuromuscular junction disorder, a very interesting disease that we come across with as myasthenia gravis. Correct? Now, when I look at this word myasthenia and gravis, what does it really mean to me? The word my goes for a muscle. The word asthenia, yes, that goes for the word weakness. And the word gravis means a grave disease. Okay. My one more suggestion to you guys is please stop uh, putting your comments in the chat box, because looking at the chat box right now, मुझे चक्कर आने लगा है. Okay, I'm having a serious vertigo giddiness. I'm not going to see the chat box at all. Okay, for next at least 10 or 15 minutes. After 10 or 15 minutes, yes, we can interact well. Let me complete a part of a topic. I'll be happy. Okay. So please be patient. The whole country is with you, right? Right. Now we've got a drug, we've got a disease, myasthenia gravis, with us. Now myasthenia gravis, as the name suggests, that it is something which is related to the muscle and the weakness, and it's a grave disorder that we are expecting it to be. Now, why does myasthenia actually happen? To understand this, let's move into a very important structure with us that we have is a neuromuscular junction. The nerve and the muscle, how are they communicating with each other? If you remember, a single something that is coming from the brain is transferring through the nerve. So we get a signal onto the nerve first, and from the nerve there is a neurotransmitter which is well released, that is known as the acetylcholine. Now we know this, the acetylcholine released from the nerve is going to attach very well onto a receptor that we understand as the acetylcholine receptor. So nerve and muscle, a neuromuscular junction, a good synapse is made very strong by a neurotransmitter flowing from the nerve to the muscle, acetylcholine. Simple. Now what happens in myasthenia gravis is this, that on top of these receptors, we suddenly find certain antibodies which are sitting. Now if you remember, these antibodies are against the receptor, which are known to me as the acetylcholine receptor antibodies. Now as you understand, these antibodies are going to do too many things. It can go and destroy the receptor. Of course, it can go and destroy the receptor. it might go and block the receptor from working, and worst case scenario could be even endocytosis. That means the receptor is drilled into the muscle, possibly, or it can be blocked or it can be killed also. That is destruction. So all this things happen. Now, what is the end result of destruction, blockage, and endocytosis of the receptor? There is some conformational change occurring on the muscle now. So what is a conformational change? It's like this. Now, what's the difference now? As you can see, receptors could be there, either destroyed, blocked, or endocytized. But what has happened? One difference, the key difference that I find in the first diagram as I made, there were good amount of synaptic folds seen. Now all these synaptic folds have got flat, and on top of it, the distance which was there between the nerve and the muscle has also increased. So there are two things now coming in a patient of myasthenia gravis. One, we find in the patient there is flattening of synaptic fold. One thing happens, and secondly, there is increase in the size of the gap between the nerve and the muscle that we know as the synaptic cleft. So the synaptic cleft, the gap between the nerve and the muscle, also happens to increase in the size, and of course there is flattening of the synaptic fold also seen. Now, where are these antibodies formed? Are they coming from outside? No, not at all. They are formed in my own body. But where are they formed? That's very important. Now, when I look into this disorder, I find the antibodies against the receptor have been formed in an organ, a lymphoid one, that is known as thymus. So look at this now. We often find a lot of thymic abnormalities in patients of myasthenia gravis, correct? Now, why does thymus only form these abnormal antibodies? Why not any other lymphoid organ? Because we find that thymus is actually producing antibody against a cell already there inside it, known as the myoid cell. Correct. So there are myoid cells present there against whom the thymus tries to create some kind of antibodies. But unfortunately, the myoid cell express some acetylcholine receptor on its surface. Now look at this. On the surface of the myoid cell, there is an acetylcholine receptor there also. So what will happen now? When these antibodies are formed against the myoid cell and against the receptor, they're going to come out from the thymus and later cross-react with the receptor. So I can think about this thing. The myoid cell antigenically mimics the acetylcholine receptor present outside. So antibody which are against the myoid cell after some time will cross-react with the acetylcholine receptor present outside the thymus. So look at the concept again. It is a sort of an autoimmune kind of a disease. That means the antibody against a thing is formed in my own body. My body is in a civil war, like this, right? Now around 75% patients of myasthenia gravis have been found to be having some kind of thymic abnormality in them. Now, if I divide this 75%, we find two things, 65% and 10%. Now, what is this 65 and 10%? They find that 65% of the time, the thymus gland is found to be hyperplastic. That means they're just working hard. I can write this line over there. They are histologically overactive. So they have not exactly increased in size, maybe, but they are working more inside, hyperplastic. And 10% of the thymic abnormality that we find is a thymoma. That is a tumor inside the thymus gland. Correct. Now there's a constant query coming, please repeat. I'll just repeat this concept. There is a muscle-like cell which is present inside the gland thymus. The name of this cell is a myoid cell. Any muscle tissue in the body carries a acetylcholine receptor on it, Same is this myoid cell, that is a muscle-like cell inside the thymus, carries an antibody as a receptor, acetylcholine inside it. So the antibody which are against the myoid cell will also act against the acetylcholine receptor. So what will happen? Once the thymus has produced these antibodies, it will come outside from the thymus and cross-react. I'm using the word cross-react with a acetylcholine receptor which is present on the patient's body, not in the thymus now. So there is a molecular mimicry happening now. So acetylcholine receptor outside on the muscle is also present inside the thymus. Now thymus starts working more like hyperplastic or thymoma tissue. So antibody which are present inside the thymus will cross-react with the receptors outside the thymus. So I repeat, myasthenia sounds like an autoimmune disorder. It means the antibody against the acetylcholine receptor is formed in my own body. It's a simple concept. No, not in a normal person. Now that's a clever doubt. Sir, in my body, oh my God, no. This happens when the thymus is working more. See, in you and me, thymus has actually regressed by now. Remember the thymus regresses with age? Yes. So we found somewhere in some people, if the thymus is working more or it's having a tumor, in only those kind of people we have this kind of antibodies, not you and me. Okay. So all is well, we are safe enough. Thymoma is a bigger problem. Thymoma is a bigger problem. Why? Because it's a tumor inside the thymus. And there are two things which can happen because of this tumor now. Local effect. Oh, I'll not draw the boxes. Sorry. Someone pointed out there are too many boxes and less space to write. I'll not draw any boxes. Okay. Because in the lockdown period, I'm traveling outside also with carrying everything in a box. I always keep on making a box. Sorry. Paraneoplastic. So thymoma as a tumor, as I understand, is something which is going to harm the patient by two things, local effect and the paraneoplastic effect. Now what is the local effect? Look at this. The thymus is located somewhere in the mediastinum and that's a tumor thymoma which is enlarging in size. So it is going to compress. It is going to compress neighboring structures and cause this kind of a compressive effect. Now look at this. Thymus is located in the mediastinum, we know. And if it increases in size, it is going to have a compressive effect on the neighboring structure, right? Paraneoplastic. Oh, again I made a box. Sorry, boss. Now paraneoplastic syndromes, there are multiple. In a thymoma patient, any kind of a paraneoplastic syndrome, that means a disease which can happen in any other system could occur in them. Okay. Right. Now, remember this. One reason why do we advise for an MRI or a CT scan of the chest? MRI of the CT scan of the chest is often advised in a patient of myasthenia. Why? Because I want to search for thymoma. And look at this. Someone is asking me, sir, should we remove thymoma? Yes, we'll come to that concept of treatment later on. If I deal with thymoma, I'm good with the patient. See, if I even have get a gland which is hyperplastic, it's working more, or it's a tumor thymoma, it's always better to remove it. Correct? So remember this, imaging of the chest, MRI or CT scan is always mandatory in a patient of myasthenia to document a thymic abnormality like hyperplasia and thymoma. If that's there, it's better to remove it. Correct? Apart from this, just a fact to be known that around 3 to 7% patients of myasthenia gravis have also been suffering with hyperthyroidism. So 3 to 7% patients with myasthenia gravis are suffering with hyperthyroidism. Okay. I've got an OCD of making boxes maybe. That's one reason. Why do we get TSH done in them? TSH is something also done in a myasthenic patient. Remember this. And because hyperthyroidism could be an associated problem in myasthenic patients. Okay. Right. So we are not too far from the actual topic, we are somewhere sitting on a disease, myasthenia, seen at the neuromuscular junction. I'll just quickly repeat. Some people are joining late, no problem. Myasthenia gravis is a muscle weakness, which is a grave disease as you come across. Disorder seen at the neuromuscular junction when the nerve and the muscle communicating with acetylcholine is not able to do so. Because against the acetylcholine receptors, we are seeing certain antibodies which are going to destroy, block, or make the receptor move into the muscle, that is endocytosis. Following that drama, there is flattening of the synaptic folds seen, and there is increase in the size of the synaptic cleft. That means the nerve and the muscle are now further apart. Where are these antibodies formed? They are formed in the gland thymus. Thymus is an organ which forms antibody against the acetylcholine receptor. Why? Because thymus possesses a cell, myoid cell inside it, and it is very well known to produce antibody against the myoid cell. But the myoid cell on the surface of it express acetylcholine receptor. So look at this. The antibody against the acetylcholine receptor in my body is produced in a factory inside me, a lymphoid organ, thymus. Simple. 65% of the time in a myasthenic patient, the gland is hyperplastic. It's histologically overactive. Thymoma, okay. Thymoma, it's 10%. That's why MRI and CT, not X-ray. See, X-ray is not a very good diagnostic tool. If a myasthenic patient comes to me, I'll not just do an X-ray. I'll also do it for a CT or MRI. Okay. Local effect compressive can happen due to thymoma, and a paraneoplastic syndrome could be seen. Additional point is this. If at all we have got with us a patient of myasthenia gravis, we should also look for hyperthyroidism in them, because 3 to 7% of myasthenic patients are shown to have hyperthyroidism also with them. Now, hyperplasia, will the size increase? No. Usually the size is found to be normal in them. It's just a gland which is histologically overactive. Okay. Now, let's look into the disease proper clinical features. How does the patient behave, a myasthenic patient? What are the clinical symptoms which we get about them? Yeah, myoid cells are present in a normal human being also. That's a genuine doubt. Yeah. But the problem is my thymus is not going to produce antibody against myoid cell that easily. Only when it is hyperplastic and a thymoma, then only it goes into that phase. Okay. What about 25%? What all antibodies are there in 25%? Genuine doubt. I'll come to that also. Okay. Let us stay here first. Now, clinical features. Remember this. In a myasthenic patient, we found that the neuromuscular junction was disordered in a sense that the nerve and the muscle, the synaptic cleft, the size had increased, and the antibodies which are against the receptor are blocking or destroying the receptor directly. So look at the diagram, please. There are 4 receptors, out of which 2 are working and 2 are not working. Just imagine in the ward, there are 4 interns with me. 2 come, 2 bunk. 2 bichara who come have to work like 4 now. I am not going to work for them. Now what happens is that 2 people have to work like 4 people. So 2 receptors have to work like 4 receptors to contract the same muscle tissue. So what will happen? They will start the activity, but gradually when the activity progresses, in the patient weakness develops. Now can you define me this symptom which I am talking about? The patient gets up from his chair, starts walking towards the door. Just a meter or 2, the patient develops weakness. What is this symptom known as? Can you define me this symptom? It's a fatigue symptom, yes, but a thing that will be there, yes. Easy fatigue, easy fatigability. So I walk for a kilometer, I get tired then only. This patient will just walk to a meter distance and get tired then only. Easy fatigue. Now the word is easy fatigue, not only fatigue, it's easy fatigue. Muscle tissue which is commonly involved in this patient, remember, are the muscles near the joint which I know as a proximal muscles. So in myasthenic patient, proximal muscle tissues are commonly involved with them. Along with this, don't forget, the involvement of the muscle tissue is unequal in them. That means it happens to be asymmetrical. That is, one muscle tissue is involved, the other one on the other side is not that equally involved. It is asymmetrical involvement. Okay. Now, find this out that the muscle group which is commonly involved is the ocular muscle group. Now, this is something very important. The most common muscle group involved in patients of myasthenia is often an ocular muscle that we find. The ocular muscle involvement could result in various symptoms. One, that is dropping of the eyelid on either side, that is ptosis. And secondly, difficulty in moving the eyeball around. That's known as ophthalmoplegia. So ophthalmoplegia and ptosis are two things which could be seen in the patient as a classical symptom with them, right? Now, just remember this, there are some ocular signs also, which were recently asked in one of the exams. Ocular signs of myasthenia gravis. Again a box, sorry. Ocular sign of myasthenia gravis. There are some ocular signs in myasthenia gravis. What are those ocular signs? Write them down. First, write them down with patience. I'll come to them and I'll show you some videos which I have with me to show you what happens in myasthenia exactly. Okay. First sign, as the name suggests, is eyelid fatigue. The ocular sign that we find in the patient is eyelid fatigue. In the eyelid fatigue in the patient, we find ptosis increases on the upward gaze. So when the patient is looking up, okay, for a duration of few seconds, suddenly the ptosis which was already there will start increasing because you cannot hold the muscles of the eye like this for a longer time. It's known as an eyelid fatigue. Second ocular sign that we know is lid twitch sign. It's known as a lid twitch sign. In the lid twitch sign, what we find is after the downward gaze in the patient is looking down. After the downward gaze, okay, the patient looks up, he maintains an upward gaze, correct, and on such an event in the patient, ptosis happens. He looks down and he looks up and maybe the eyelid overshoots in him and suddenly the ptosis happen in such patients. Lid twitch sign. Don't worry, just keep on writing them. I'll come to this concept later on, why all these things happen and how do they really look. Curtain sign. Why are the proximal muscles involved in myasthenia gravis more frequently? A genuine doubt which even I asked my professors once. They told me that the proximal muscles have got larger density of the acetylcholine receptors and those antibodies are going to attack them and kill them. While in the distal tissue, the receptors which are there, acetylcholine, are quite far off. So it is a high possibility in them that out of 20 receptors which are in the distal muscle, 10 are infected, 10 are unaffected because they are sparse off, they're away from each other. So that's one good reason why ocular muscles involvement is most commonly seen in them, which I always regard as a proximal muscle because the density of the acetylcholine receptor is quite good enough in them. So antibodies come at a point and attack every receptor, so things happen quite quickly in them. Okay, curtain sign. Curtain sign is that a sign in which raising the ptotic eyelid in the patient, opposite eyelid falls. That means if I'm having ptosis on this side, I raise it and the other side was normal, suddenly the opposite eyelid will fall down. It's all becoming like a curtain. It's coming down like a curtain. Fourth, smooth muscles. Yeah, smooth muscles. I'll come to the smooth muscles also. I'll explain that also, what happens to the smooth muscles in these patients. Peak sign. Now this is something which has been asked at least thrice in all the exams I've seen. Very interesting sign, peak sign. In the peak sign, what we find with the patient, there is inability to maintain sustained closure of the eyelid. That means the eyelid which was being closed suddenly opens up as if the person is trying to peek inside or peek outside. Peek sign. Okay, let's show all these signs to you once. Okay, first I'll show you this eyelid fatigue. This is a video which I try to record on eyelid fatigue. Okay, we go back again. On the sustained upward gaze in the patient, the ptosis happen. So the person looks up and suddenly the ptosis happens in him. That is known as eyelid fatigue. Okay. Don't worry, there is some emesis fugax also today. Okay. Now look at this. After a downward gaze and upward gaze. Downward gaze we could not record. Downward gaze and then the upward gaze. There is falling of the eyelid ptosis along with some twitching of the eyelid, because when the eyelids are falling down like this, there's always a contraction to keep it open. So that kind of a contraction will give a typical twist sign to me. Okay. Right. Now looking at another sign, a curtain sign. On raising the ptotic eyelid, the eyelid which was opposite normal will fall down. So everything will come down like a curtain. So when I raise the ptotic eyelid, the opposite eyelid which was normal, we could not record it so well, but just understand, on raising the ptotic eyelid, the opposite eyelid that was normal will also fall down. Okay, like a curtain, it will come down like a curtain sign, right? Thank you for the family members. No, Dr. Manish Chabra in Opthal of our dams had recorded all these videos long back for me. Okay, thanks to him. Now this is the sign which I was telling you, very, very important sign is the peak sign. Peak sign. In peak sign is this, when we tell the patient to close the eyelid tightly, after a few seconds we find him opening the eyelid slightly. Now look at this. We are trying to play a game which I play with my kids also. Peekaboo, that's a peaking sign, in which I just try to open a bit of my eyelid and try to see through a small slit. No. So look at this gentleman, old man of course. He is having closed eyelids totally. He is trying to close it completely for a longer time. And suddenly he opens his eyelid slightly like this, as if he's trying to see through a small hole. Okay. That is known as a sign, peak sign, as if I'm trying to see through a small hole. Okay. That's known as a peak sign. Okay. Right. We have got another manifestation. Yeah. Genuine doubt came in. So is it unilateral or bilateral? Yes, it's bilateral. Not unilateral. Sorry, not bilateral. It's most of the time unilateral. For explaining purpose, I've used on both the sides. Okay. But most of the patients of myasthenia, when they come to me, they are asymmetrical, as I told you. They are only on one side, not on the other side. Second, facial muscle. Remember this. Facial muscles in myasthenia gravis are involved. After the ocular, number 2 muscle group is the facial muscle group. An involvement of the facial muscle group, remember this, will give a typical appearance on the face. That is known as the snarling appearance on the face. The snarling appearance. Now what is this snarling appearance? It's nothing but a vertical smile on the face that we find. Now if I smile, like if I try to smile, and you also smile with me please, muskuraiye. You are in corona epidemic. And I tell you muskuraiye, you are in corona epidemic. How will you smile? Sir, what a pandemic, sir. So that's a smile which is not horizontal, it's more vertical smile. I'll show that video also. What it mean? Yeah. Vertical smile, I still remember in my marriage, the videos were always having this appearance all the time with me, snarling appearance, because on the other end, the cameraman was trying to make me smile. मुस्कुराइए सर, शादी है आपकी. Okay, vertical smile. Now, another concept, I can show you another image of vertical smile. I've got another great man. Yeah, America. It's a Chinese virus. Inject disinfectants. Okay, I'll kill everyone. So this great gentleman requires a really applaud. He should be awarded as a Nobel Prize for everything that he tries to do for America. So he's having a typical. So why is it known as snarl? If you go to Google the word snarl, somewhere we find the word snarl is like a loud cry of a wild animal. Now, don't look at Donald Trump for this. I'm not offending him. It's like a wild cry of a animal in a jungle. If they want to call out someone like a dog or a wolf, they always snarl like this. Ooh. So you can see the typical snarling appearance. Okay. God bless America, but one thing. Now, there's another thing that we find in these patients. If we go into the facial, we go into the pharyngeal and the tongue muscles. Remember this. These patients have got a mushy voice with a nasal timbre in the speech. They often get a mushy voice with a nasal timbre in the speech in patients of myasthenia gravis. Okay, although I'm writing it under the facial, but still it's a part of the pharynx and the oral cavity. How is this mushy voice with a nasal timbre? Just imagine people fasting the whole day, really great people, and in iftar they want to eat something and they find something in their hand which they don't know the temperature and they just put it in the mouth. Now what happens? If I put anything hot into my mouth, how will I speak? Oh my God, my mouth is burning. So I will not speak always like this. Whenever anything like this is in my mouth, I'll talk like this. Oh God, my mouth is burning. So whenever I put on my voice, it comes out from the nasal cavity. It's a nasal timbre of the speech that comes with them. And these patients have got difficulty in articulation of speech because of the tongue muscle getting involved. That will create a typical mushy voice in them. So mushy voice and nasal timbre, yeah, you can put that as hot potato, it's fine. But hot potato voice is always described in some other disorder. I don't want to put it there. So mushy voice with a nasal timbre could be found in them. Maybe they are just like Himesh Reshammiya, if you have heard that singer. Yeah, they always sing with a nasal timbre. Tera 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 surur. Okay. Number 3, skeletal. So the first muscle group that we have with us is the ocular muscle involved in myasthenic patients. The second muscle group after that is a facial muscle. And the third muscle group that we have is the skeletal muscle. So these are the 3 muscle groups typically involved in a myasthenic patient, and 1, 2 and 3 is the actual order of involvement also. Okay. So the least common is a skeletal and the most common is ocular. Now find this out, a very important thing. Few things are still normal. Few things are still normal in myasthenia gravis patients. What are the things which are normal? Write it down. The deep tendon reflexes. Deep tendon reflexes are typically normal in these patients. When I check a jerk, knee jerk, ankle jerk, anything like this, I put the knee hammer deeply on the tendon. It's quite commonly normal in them. See, what happens is, when I strike a knee hammer on a tendon deeply, I'm sending a signal to the brain and a signal is coming out. Initially, I'm using the word initially. In these patients, the deep tendon reflex will be normal. So when I check a jerk, look at me. Even when you go and check a jerk yourself, you use a knee hammer and you strike it once and twice. You don't strike it, keep on striking it. It's not a nail that you are fitting inside. Okay. So please, if when you do a deep tendon reflex, it is just a single or 1 or 2 contraction of the muscle. So initially I'm using the word. Deep tendon reflex in the patient will be normal. But when I keep on doing it, the muscle will develop fatigue. So I'm using the word initially over there. Deep tendon reflexes are typically normal in them. Sensory system is perfectly involved in them. Okay. Bladder is also normal in them. And of course, the brain cognition is well perfect. So the cognition understanding part is normal, the bladder is normal, the sensory system is intact, and the deep tendon reflexes I used the word initially in the disease could be normal in myasthenic patients. A fact to be known. Now another fact is this, the disease. When I look at the incidence of the disorder, it is 3:2. 3:2 in the sense that it's more frequent in females than males. So it's more frequent in females than males. As a disease, as we come across with them, 3:2 ratio, that is more frequent in females than males. Habit of making boxes. I'll become boxer one day or what? Mukkebaz. Apart from this, write this down, is this. Age of onset. Now this is something very important to note. When does a disease really come to us? Age of onset. It could be between the age of 20 to 30 years, or it can happen between the age of 50 to 60 years. Remember this fact. In females, it occurs more often in the bracket of 20 to 30 years, and in males occurs between the bracket of 50 to 60 years. So it's early onset in females. F stands for females. It's early onset in females and late onset in males that we find in myasthenic patients. Okay. Now let's look into the investigation part. When I want to understand the investigation part, see the two peaks word is like this. When I look in the females, the incidence is commonly seen in the onset between 20 to 30 years. In males, the onset is between 50 to 60 years. After 60 years, that's why I made a peak. After 60 years, it won't be happening in males. After the 30 years time in females, it won't be occurring. That's why I made a peak graphs. Nowadays, we are busy seeing so many graphs. I made a graph again. And sorry for the box. Investigation. We need to understand it from the very basic. Why does myasthenia happen? Let me talk about it again in a very short kind of thing. Like it's a neuromuscular junction. The muscle has got flattened, and the distance between the nerve and the muscle has increased, right? So the nerve, which is synthesizing an acetylcholine molecule inside it, would be releasing it outside into the synaptic cleft, and now the receptor, which is present on the muscle tissue, won't be able to get it because the antibodies have got destroyed, or rather blocked, the receptor. Now what we find is the two receptors are working like four. Two receptors are working like four receptors, and initially they are trying to contract the muscle tissue. But unfortunately, they cannot really work so hard. So they also get tired and fatigued. Now look at this. Two receptors, please listen to me carefully, don't type anything there. Two receptors are initially working like four receptors. So I've made four kind of ticks over there. After some time working more, they will get switched off. They will not work at all. I'm putting an arrow. And after some time we find with them, they come back normal. See, two receptors are working like four receptors. They will get tired, they will get fatigued, then stop working. But after some time they again come back to work. But when they come back to work, they find a problem. There is no acetylcholine in the synaptic cleft. Why? I hope you know. There is an enzyme present in the synaptic cleft, always there to eat it away. The name is acetylcholine esterase, which will actually decrease the acetylcholine level progressively, because that molecule is still there, but no one is utilizing it because the receptor is either dead or blocked. Now look at this. If I inhibit the acetylcholine esterase enzyme, what would happen? The acetylcholine level will build up in the synaptic cleft. When that happens, what would occur? The two receptors which have come back from a break will see the acetylcholine molecule and will start depolarizing. So look at this. At this stage, they are overburdened. They are working more. At this stage, they are totally fatigued out. They are not working at all. At this stage, they are normal. But the problem is the acetylcholine molecule is not there for them. So when they see the molecule, because the enzyme which is eating away this molecule has been inhibited, they will start working normally, correct? Now can you tell me the name of this drug, which is an acetylcholine esterase inhibitor, which could be used for diagnostic purpose in them? Yes. The name is nothing but your edrophonium. It's a short acting, it is a faster acting congener. So the drug is edrophonium and the name of the test is edrophonium test. Please do remember edrophonium is somewhere available to me in a trade name which is known as a tensolon. So we label this as a tensolon test to the patient. So it's a edrophonium or a tensolon test which is initially done in the patient. But remember, how do we go and do this test? You should know the methodology also. We inject the patient 2 mg edrophonium, 2 mg edrophonium through the route intravenous or IV route. Then we look into the patient weakness. How is the weakness occurring in the patient? Now there are two patients. Either in the patient on giving 2 mg edrophonium, the weakness improves. If the weakness improves in the patient, yes, that's a case of myasthenia gravis for me. But if at all the weakness is unchanged, that means the weakness is still persisting in the patient, it's unchanged. What could happen? If the weakness is unchanged, now we are not going to quit. We are going to give our patient 8 mg IV edrophonium. And now we look at the improvement part. Now if the weakness improves on giving 8 mg IV edrophonium, then we are classically very sure it's a clear case of myasthenia. But on giving 8 mg edrophonium again, we find with the patient the weakness that we found is unchanged. Okay, sorry. The weakness that we found is unchanged. Then it's not a case of myasthenia gravis at all. So I'll put the variable weakness over here. WK stands for weakness. So look at this. First you give 2 mg edrophonium to the patient. If the patient weakness improves, it's a myasthenic patient. If at all the weakness is unchanged, then you give 8 mg edrophonium. Then again you look for the weakness part. If the weakness improves in the patient, it's a myasthenic patient. If it is unchanged, it's not a myasthenic patient. Yes, you are correct. Why did we do in a stepwise manner? Because we are scared of what? Edrophonium. If the edrophonium acts too much too quick, what will happen? A lot of acetylcholine will rise in the synaptic cleft. And what will my dear patient end up with? A big disaster, a big problem which you know as what? Cholinergic crisis. So we are scared of cholinergic crisis kind of a disease which could occur when we do an edrophonium test in the patient. Right. So what do? Whenever we are advising for this edrophonium test, we should always keep an injectable thing standby, because in case we have got the disease like cholinergic crisis, we should be able to deal it as quickly as possible. Yes, the name of that injectable which we keep always standby while doing this test is what? Atropine. So whenever you do an edrophonium test in your hospital or OPD anywhere, you should always keep atropine standby with yourself, because if in case you're getting all this kind of a problem, you should be able to give an antidote beforehand. Yes. Second test, the problem was like, edrophonium was a test which was good, more scientific anytime, but we found that we have to really be very careful in doing this edrophonium or the tensolon test, because most of the patients that we did in our OPD also landed up with a cholinergic crisis. So what should I do? Another test which the ophthal people suggested me is known as a ISPEC test. Now what do you do in the ISPEC test? In the ISPEC test, we apply ISPAC over the ptotic eyelid. So eyelid which was having ptosis, which has fallen down because of disorder, we apply an ISPAC there for a duration of 2 minutes. And now we look at the end result. If in the patient weakness, or rather I can use the word ptosis now, the ptosis in the patient improves, this is something suggestive of myasthenia gravis for me. Now what is the rationale of this test? Look at this. The ice pack that you apply, the ice pack actually is giving us a cold environment, and cold environment has got an inhibitory influence on the acetylcholine esterase enzyme. We came to know later on about this kind of a thing, that the esterase enzyme which was eating away or hydrolyzing the acetylcholine molecule could be inhibited by a cold environment also, by applying what? An ice pack. So that's the rationale of this test. Okay. Applying an ice, giving a cold environment locally could inhibit this enzyme and get a good improvement in my patient. Now please remember, this is something quite recent. Ice pack test is nowadays considered to be a very good screening test for myasthenia gravis. So when we look into the disorder and when we want to screen the disorder, always we go for a non-invasive kind of a test known as the ice pack test. That's a screening test considered for the disease. Okay. Now be careful on this 2 minutes time, because I remember in my OPD I advised for an ice pack test and I told the patient to keep it for 2 minutes, and the patient kept it there, and I just went away for some other work. After 15 minutes he opened the ice pack, and to my surprise the patient's ptosis could not improve. Even the eyelid could not open now, because the eyelids have got freezed by the ice pack. So be careful when you are doing this test. You should not do it for a prolonged time. Only 2 minutes is sufficient. Okay. Number 3. Now number 3 test that we can advise in the patient is the epicenter of the problem known as the acetylcholine receptor antibodies. Now these antibodies are found here only, nowhere else. Okay. So these antibodies are found here only, nowhere else, known as the acetylcholine receptor antibodies. Now that's why the book says that the most specific test for diagnosing myasthenia gravis is the acetylcholine receptor antibodies, because they are found here only, nowhere else. They specify me about the disorder. But a word of caution, like conditions apply here also. These antibodies are positive in 85% of people with generalized myasthenia gravis. Generalized myasthenia gravis is a disease myasthenia which is present all across the body. As the word suggests, it's generalized, not only eye, not only face, it could be on the skeletal muscles also. And they are positive in 50% of people with ocular myasthenia gravis. Now what do you mean by the word ocular this time? The word ocular means the eye muscle show weakness. So weakness is present in the eye muscle, and I'll write the word only. Only the eye muscles are weak in the patient for a duration of 3 years time. So please remember, the definition part is very important here. For 3 years time in a myasthenic patient, we consider the eye muscles are only weak. That is known as the ocular myasthenia. If it has gone beyond the eye, on the face and the body, it is known as the generalized. So 85% of generalized people find it positive. 15% people with generalized myasthenia won't have these antibodies. Now be careful. 50% of ocular will have these antibodies, while 50% of ocular are not going to have these antibodies. So I can write this line and try to understand this line. Negative test does not exclude myasthenia gravis. That means a myasthenic patient has come to me and I advise for an acetylcholine receptor antibody and they come to me negative. I may not send the patient home saying, no, you don't have myasthenia. Yes, it can happen, because it's not always positive in every patient of myasthenia. So negative test does not exclude myasthenia gravis is a very important statement. But what 3 years means, that for 3 years time, from the onset of the disease till 3 years time, in the patient only ocular muscles are weak, no facial, no body, no skeletal muscle involvement. For 3 years time, we require eye muscles to be weak, and only for eye muscles that is defined as ocular. Okay. Why is it then specific? See, acetylcholine receptor antibodies are not routinely found in a general population or any other disorder. There are few cases of false positive also, but not very commonly seen. So it really specify me about the disease. Yeah, it may be this disease. So if a patient comes to me with acetylcholine receptor antibody, I think of only one thing, myasthenia, nothing more than that. Okay. Third patient or third investigation, if these antibodies are negative, then what is the third investigation? Now, please be careful. It is muscle specific. Pay attention to this. This is something very important. Muscle specific tyrosine kinase antibodies. Muscle specific tyrosine kinase antibodies. Right? Oh, fourth point. That means you are attentive. Thank you. I thought you were sleeping in your bedroom. Okay, not sleeping. Good. Bedroom became classroom, and the classroom was earlier bedroom. Bad joke. MuSK, muscle specific kinase antibodies. Okay. Now, what are these antibodies doing, and what is the MuSK enzyme doing for me? This is the nerve. That's a normal neuromuscular junction transmission for me. Okay. Now, muscle is having the acetylcholine receptors with it. Now, when I look at the acetylcholine receptors, it's not a single molecule kind of a thing. At least 5 subunits are there with me to make up this acetylcholine receptor. Now, what are those subunits? It is 2 alpha, 1 beta, 1 gamma, and 1 delta. So these are some, I don't know what language do you claim them to be, alpha, beta, gamma and delta. Okay. So these are the 5 subunits, and 2 alpha subunits are the most important of Y. Now look at this diagram. The 2 alpha subunits are making the acetylcholine receptor prominent. How? These 2 alpha subunits are somewhere located on the muscle tissue, and they're exposing themselves towards the synaptic cleft and also digging their foot into the muscle tissue. So now what happens? The acetylcholine is released from the muscle and nerve, and it is reaching the receptor there. Now this alpha subunit of the receptor will try to open up like this. Now look at the direction of the arrows. It will open like a gate to make a cation enter the muscle, and that cation is nothing but my sodium. So when the acetylcholine molecule comes on the receptor, yes, it tries to open up the gate of the alpha subunit of the receptor. Okay. And now what happens? The sodium influx occurs into the muscle. If you remember, in the very first class I was talking about this. Nerve or muscle anytime internally in a resting stage is negatively charged. If it fires positive, it becomes depolarized. Now sodium comes in, depolarization happens. What is depolarization? That means the inner charge becomes what? Positive. Now this sodium coming into the muscle tissue will generate an end plate potential. EPP is the abbreviated name for this. So end plate potential is generated inside the muscle by the influx of sodium anytime. Now what happens? The end plate potential everywhere will add up together to reach a potential which we know as the threshold potential. So remember this, depolarization is not by a single sodium coming into the muscle. Sodium comes at various points to generate an end plate potential, and all of them add up together to reach what? Threshold potential, right? Now, the most important thing in them is the teamwork that we find. What is the kind of a teamwork now? In the muscle tissue, all these receptors should be together at a point. Then only I am able to add on all the end plate potential and reach a threshold potential. But how are these receptors together? Now find this out. I'm putting an arrow thing, orange thing here to explain it. So all these receptors are actually held up together by the help of some enzyme. Now this, which I've drawn with this orange kind of a thing, is the enzyme known as MuSK enzyme. Now look at this. Muscle specific kinase is an enzyme which will work inside the muscle and it will help all the receptors stay together. Now if I want to use the word together, that means I'm keeping it together. We know this term as what? Clustering. So all these receptors are kept together by the method of clustering when the enzyme MuSK works on it. Okay. But remember this, it's a kinase, it's an enzyme. Whenever the enzymes are there in me, I require a particular stimulus for it also to work. Now there is something which is present already in the muscle which will stimulate this muscle enzyme. That is LRP4 and agrin. Just note this down, don't go into details, just the abbreviated name and the name is fine. So look at this one. In the muscle tissue, there are two proteins already there, LRP4 and agrin, which are going to combine and stimulate this MuSK enzyme. And what is the MuSK enzyme going to do? Cluster all the receptors present in the muscle. Keep them together. Okay, that's a simple concept. Antibodies. We found antibodies. I know some people are not attentive in the class, that's why they're saying repeat. I'll just put it again. Pay attention, please. This time will never come back. Muscle specific tyrosine kinase antibodies. Acetylcholine released from the nerve, coming in the synaptic cleft, opening the alpha subunit of the receptor, making the sodium come into the muscle. Sodium coming into the muscle will generate a small end plate potential, EPP. End plate potential at various points in the muscle will together add on to reach a threshold potential to contract the muscle. Now the problem is, if all the receptors are away from each other, it's very difficult to reach a threshold potential. So I need to keep all the receptors together. To keep them together, I require this enzyme MuSK now. So this is my enzyme MuSK present between the receptors in the muscle tissue, and it is going to keep all the receptors together, known as the word clustering, keeping them together. But to make the enzyme work, there are two proteins in the muscle already there to stimulate it, that are LRP4 and agrin. They're going to combine and stimulate the MuSK enzyme. Okay. Antibodies. Antibodies are present against the MuSK enzyme. Now if there are antibody against the MuSK enzyme, what will happen? It will decrease what? Clustering. So the clustering, that means keeping all the receptors together, will be obviously inhibited if you got antibody against this enzyme. Write this down. MuSK enzyme is positive in just 10% of myasthenic patient. Only 10% of myasthenic patient are going to find this MuSK enzyme positive with them. And they're often found to be positive in a disorder that we know as a name, bulbar myasthenia gravis. Now find this name bulbar. We'll discuss in the live classes again about this concept. There's a problem known as dysarthria and dysphagia. If you know these terms, is good. Dysarthria means difficulty in articulation, arthria, speaking, speech output. Dysphagia means difficulty in swallowing. So a patient of myasthenia gravis has got difficulty in speaking out and difficulty in swallowing. That means, if you remember that hot potato voice that you told me, mushy voice with the nasal timbre, yes, it could be found in a disease myasthenia, and that's the only complaint. Now look at this. In bulbar myasthenia patients, they only get dysarthria and dysphagia as a complaint. So that is defined and labeled as a word bulbar myasthenia. Like ocular myasthenia, as I told you, is eye muscles involved only for a duration of 3 years. That is ocular. If it is only the pharynx and the tongue muscle involved, it is known as bulbar myasthenia. Okay. Please also write this down. We got antibodies against LRP4 also. Now, if you're attentive, please tell me if LRP4 antibodies are present, what will decrease in the patient now? If you're attentive, you'll be able to answer me. If LRP4 antibodies are present in a patient, what will decrease in the patient? Clustering, not musk. Clustering. Are Baba, antibody against musk activity. That's a correct answer. Good. Musk activity will decrease. That's a correct answer. Not musk. Musk will not die. Musk is already there with me. I don't have antibody against musk, but I got antibody against LRP4. So if I got an antibody against LRP4, what will happen? It will not stimulate musk enzyme and it will indirectly, I'm using the word indirectly, decrease clustering. Okay. So it's a very simple concept. Please pay attention to this. So how many antibodies at the end that we get? We found antibody against the acetylcholine receptor, the main culprit, the chief villain. We also got antibody against the musk enzyme and LRP4. Now just a bit of information on LRP4, because 2 years back we got a question on this also. They are positive in only 1 to 4% patients of myasthenia gravis. So just 1 to 4% myasthenic patients are going to find these antibodies, not every patient. Okay. Now another investigation, which is slightly an invasive one, is known as rapid nerve stimulation, being abbreviated to me as a term RNS. Now what is this rapid nerve stimulation with us? Okay, let me look into the diagram. The neuromuscular junction was there with me. Acetylcholine was formed here, often released out into the synaptic cleft, happily attaching onto the receptor below in the muscle tissue. On the receptor, we got antibodies which are blocking or destroying the receptor every time. What I do now is I rapidly stimulate the nerve. Now look at this. I give a stimulation to the nerve rapidly. It will increase what? Acetylcholine release. And what will happen? The two receptors will start working like 4 receptors. So pay attention again. I rapidly stimulate the nerve. I release acetylcholine from the nerve. And I give a stimulation to the receptors which are there vacant on the muscle tissue. So what am I going to generate there? Action potential? Correct. So I'll do one thing. I'll record this as a graph. On this axis, I'll put the word AP or action potential in the muscle. Now look at this. I'm stimulating the nerve this time and I'm recording the action potential in the muscle, not in the nerve at all. So what is a graph kind of a thing I'll find? Look at this graph. First, second, and maybe the third. First, second, and the third stimulation that I give from the nerve, the action potential in the muscle is found to be normal, like you and me. Why? As I told you earlier, 2 people can start the work like 4 people. Initially, they will be looking like a normal person, but now they're getting overburdened, so will they what? Fatigue. Now, because of this fatigue, I find the 4th and the 5th stimulation that I give from the nerve, the action potential will start decreasing by a minimum magnitude of 10%. So look at this. I keep on stimulating the nerve, the muscle that is supposed to get the message from the molecule, correct? And now the molecule is coming on the muscle tissue and 2 receptors which are working like 4 are initially working. But now they're getting overburdened, they're getting fatigued. So the action potential that was previously there will start decreasing by a minimum magnitude of 10% on the 4th and the 5th stimulation of the nerve. So look at this response. Can you give me a name? Yeah, good. Someone has already answered this. This is known as a very typical response that we find in myasthenic patient. Decremental response. Correct? Now, why do we use the word decremental here? Because if I keep on stimulating the nerve, the action potential in the muscle should remain there. But now action potential starts decreasing early in the disease. It's a decremental thing happening. Now, can you tell me what can I equate it to clinically? What clinical feature does the decremental response equate to? It's a very simple question. What clinical feature in the patient does the decremental response equate to? You know the answer, it's very simple. Yes, the fatigue or the easy fatigue. So easy fatigability as a symptom which we found in the patient could be found electrophysiologically by a response known as the decremental response. Okay, so that's fine. Number 6, number 6 is a term which we apply here is a single fiber EMG. Pay attention to this name, single fiber electromyography or SFEMG. Now what do we do in this? We take the we take the nerve, okay, and we record action potential in the muscle. So please be careful, it's something very complex to understand. The EMG word stands for electromyography. Electromyography, right? Look at this, please. These are the muscle spindles, okay, which are present in a fiber of the muscle. So we do one thing, we take a single fiber of the muscle. Now what we do a refined kind of a thing. We check in the muscle a single fiber with a lot of muscle spindles inside it. So these dots or the 4 circles which I have drawn are the part of a single fiber of a muscle. Okay. Now in a normal circumstances, what do I get? At 4 points inside the single fiber of the muscle, which is innervated by a single nerve actually, the action potential in all 4 of them is what? Equal. Why? Because all the muscle fibers are very well working, there's no problem at all in them. So if I look into the single fiber, we don't stimulate anything. Now that's very important question. Do we stimulate the nerve this time? No. We let the normal stimulation of the body happen. Now we tell the patient just to contract the muscle or something. That's a normal stimulation. So in a normal circumstances, the action potential in a single fiber at all the 4 points is equal and normal. Correct. Now tell me, what will be the thing in myasthenia gravis? Apply your mind in a single fiber where the antibodies are so many against the fiber, against the receptor. Will the antibody making the receptor work or no? No, they're going to cause a problem. So you might see that the action potential, action potential, action potential, and action potential. Maybe I'm just giving an example. 2 of the points it will not have, 2 of the points it will be there. So we are going to see what now? If you try to make it in a clinical way, in a muscle tissue, normal, the action potential at every point is equal. But in myasthenic patient, the action potential found in a single fiber is different or unequal. I can use the word unequal better. Now this inequality in the action potential which is noted down in a single fiber, please remember, has got an electrophysiological name as a jitter. So there is a jitter recorded in these patients. That means the jitter rises in these patients. Remember this. So there is a different or an unequal kind of action potential recorded in a myasthenic patient in a single fiber of the muscle. That is known as jitter, and jitter rises in them. Okay. Just write this down. The most sensitive test The most sensitive test for myasthenic patient is a single fiber EMG. So most sensitive test in diagnosis of myasthenic patient is always a single fiber EMG. Now student came back with a different doubt, sir, why don't you write EMG over there? Every time you are making us write SFEMG, why? I'll tell you why, because EMG is not the ideal investigation to be done. There's a reason behind this. Electromyography, I'm putting electrodes in the muscle. I'm not doing a refined technique like a single fiber kind of a thing. So the problem and the limitation of this technique is this. In an EMG technique that we do, the jitter kind of a experience is often not recorded. So when you want to record a jitter kind of a thing in a muscle tissue, you require a single fiber EMG as a technique, not an EMG. At your level, please remember, even if you know the terms SFEMG, jitter, most sensitive test, more than sufficient. More than sufficient. Okay. EMG is not recording a jitter, so that's why the EMG is a word which we should be careful about. It's not EMG, it's SFEMG. Now remember this, the best test. The best test for diagnosing myasthenia gravis anytime is a single fiber EMG, followed by a test known as the hydrophonium or the tensilon that we do, followed by the RNS technique. Now they've done a lot of trials and comparative things on each one of them. See, SFEMG, hydrophonium and RNS are the three tests, the basic ones, in which they found the best anytime is SFEMG recording the jitter, followed by the hydrophonium, followed by the RNS. Okay. Yeah. Some of the students got me correct, sir. Are you telling me it's a single motor unit? Yes. See, if you read this concept in physiology, nerve supplying 4 points. That means 4 points in the muscle. Okay, 4 point in the muscle getting a supply from a single nerve is known as a single motor unit. So this is single motor unit. That means the nerve is supplying 4 points in the muscle, and all those 4 points we put electrodes, and normal condition we find that the action potential is equal with them. Myasthenic patient, we find a difference or inequality in action potential because those 4 points, maybe 2 of them are working, 2 of them have been blocked or destroyed by the antibody, and that difference or inequality in the action potential in myasthenic patient is defined as a jitter. So jitter excessively rises in them. Be careful. Fasciculation, fibrillation, leave that thing. You'll deal in physiology better. Just remember, for myasthenia, the word is jitter. Fine. The treatment part. Treatment part. Okay, there's one doubt coming very often in the class. Class is till 9:30 p.m. I may take 10 minutes extra. Please excuse me for that. Don't punish me. Okay, maybe I can just take 5 or 10 minutes extra for discussing the MCQs that we routinely do at the end of the class. Okay, so don't ask this question again. Okay, and now a student who asks for break, I always tell, Gunah hai ye gunah. Not even 2 minutes joke. Okay. So don't do this gunah. Trump will come and fire you. God bless America. Right. Now one good treatment that we have is this. Acetylcholine esterase inhibitor. Now acetylcholine esterase inhibitor are drugs which we can use in the patient, and it is going to progressively increase the acetylcholine level in the cleft, and it's going to improve the weakness in the patient. Okay. Now what we find is this. 2 drugs which are longer acting, peripherally acting, pyridostigmine. One drug again longer acting is neostigmine. Now the bigger controversy is that which is the drug of choice in myasthenic patient. I'll clear this controversy again. Now Pyrido versus Neo. When I look at the effect the actual effect which is created by the drugs, the acetylcholine level rises in both of them. It increases in neostigmine actually more as compared to a pyridostigmine injectable, right? But the problem here again is if the acetylcholine level rises too much, what will be the problem with the patient? Yes, the problem which I'm really worried with is cholinergic crisis. So giving a neostigmine to the patient can land the patient to cholinergic crisis. So what to do? Okay, what we do is that pyridostigmine, now commercial availability I'm talking about, is oral, and neostigmine commercially availability till date in India at least is injectable. Now just imagine you put a patient on a neostigmine injectable at home. He might comply you for at least 1 or 2 days, but day 3 is going to change the doctor. He is always going to find a doctor who always give him a tablet to take. So please do remember and don't forget this. In pharmac also, in DAMS we keep on telling this concept. The drug of choice any time for myasthenic patient is a pyridostigmine. Okay. But a student did a big blunder once. He very proudly marked the answer as physostigmine. Physostigmine. Possibly he got confused with the surnames Kapoor and Sons, Stigmine, all Kapoor and Sons. Please remember, physostigmine is not the ideal drug to be given. Why? Because if you ever read it somewhere, it is centrally acting. So remember this, physostigmine is not the ideal drug, it's centrally acting. We require a drug at the neuromuscular junction to work. That is pyridostigmine, better. Second one, another group of treatment, don't forget, is the immunosuppressants that we have with us. Now, immunosuppressants are various kinds, There are 3 classifications of immunosuppressants that I could read in the book. One drug which will give me an immediate response. Okay. The second group of drug will be one drug which will give me a short-term response. And the third wala is a drug which will give me a delayed response. Now, how do we classify them like this? One drug which is giving me an immediate response is mine. That is a drug which I give and immediately in the patient I find a response coming in. So in a myasthenic patient, we gave a drug and we found in them immediately the patient improved, immediate response. Okay. Short-term response is a term, or maybe an intermediate response also some of the authors have given, in which they write that the response appear response appear 1 to 3 months later. So short-term response appears 1 to 3 months later. That means we start the drug and after 1 or 3 months of therapy we expect a response to come in the patient. That is known as the short-term. So the word short-term, you should not carry home the message like it only works for 1 or 2 to 3 months. No. So short-term means the response appears 1 to 3 months later on starting a particular immunosuppressant. Now the word delayed. Now there's a lot of controversy on delayed also. But I could follow in Harrison that the response appears, almost 1 year later. That means we started that drug and after a year time of giving in that immunosuppressant, we happen to see some kind of response coming in the patient. Okay. Now what are the drugs which are going to give me an immediate response? Just imagine this. There are antibodies against the acetylcholine receptor already there in my body causing myasthenia. So I can do one thing. I can give antibody against the antibody, right? What are that category of treatment? Is nothing but your IV IgG. IVIG stands for intravenous immunoglobulin. Okay. Second technique that we can do is to take out the patient's blood, filter it out, and give a new blood or the same blood back to the patient maybe. What is that known as? Plasma pheresis. So these are the two techniques which I understand will be given to the patient, and suddenly we'll see a good response coming in immediately. That's why the word immediate response is given to them. But in the background, if you work in the hospital somewhere, you'll find that IVIG therapy is very costly. And plasma pheresis, hardly any hospital knows how to do it. So one drug available, yes, patient doesn't buy it. Another therapy available, the doctor doesn't do it. So what do we do? There is a recommendation for this. Remember, IVIG in plasma pheresis is often done in people with refractory myasthenia gravis. That means the patients of myasthenia who are not showing any kind of an improvement, refractory people. And second group of people who are in real trouble. That means they are in myasthenic crisis. Now find this name out, crisis. Crisis means a serious problem, crisis. Okay. Now what do you understand by the word crisis over here? In a myasthenic patient, the word crisis stands for respiratory muscle weakness. That is, there is a patient of myasthenia with me and he has got intercostal and diaphragm muscles weak today. That means he is going to die. He requires a ventilatory support. Yes, that is known as a myasthenic crisis. But the point here is what would precipitate, I am using the word PPT for precipitate word here, infection. Remember, infection is something which can happen to any one of us. So infection in myasthenic patients, any kind of infection can precipitate crisis. Crisis in myasthenic means respiratory muscle weakness. And don't forget to take out of the crisis the Sanjeevani booty. Sanjeevani booty every time is IVIG and plasma pheresis. I hope you know the Sanjeevani booty. Lord Hanuman bought for Lord Lakshman or Lord Ram. You should know that. Ramayana also somewhere. Okay. Because you never know, you are in KBC and this question comes there. You'll be very sorry to answer that there. Okay. GCT. Now look at this. Short-term response. That means the response appears 1 to 3 months later by 3 kinds of drug. GCT. G stands for the glucocorticoids. C stands for cyclosporin. And T stands for tacrolimus. Okay. Glucocorticoids, cyclosporin and tacrolimus, these are the 3 drugs which are given myasthenic patient and the response will come 1 to 3 months later. Okay. Now a response which is considered to be a short-term response. So please don't type anything. Khamosh. Okay. MNA. M stands for mycophenolate mofetil. MMF, a very important immunosuppressant, and the second one is azathioprine. So azathioprine and mycophenolate mofetil is something that is given as an immunosuppressant in myasthenic patient, but the response appears 1 year later after starting the therapy, and it is considered to be a delayed response. Okay. So just remember the names of these drugs. Okay. Short term, long term, and a delayed response. What are the drugs available with us? How does IVIG work? You know, in Harrison, they are very clever. They just say, we don't know. It is of unknown region or unknown thing. But what I understood from my college teachers is that, see, there are antibodies already there with me. So I give some antibody against the antibody. Okay. So what we do is we give antibody against the receptor antibody. So these antibodies which I give from outside are actually acting against the acetylcholine receptor antibodies. So they're going to clash and kill it. Okay. Now, number 3 is a surgical treatment. Now, pay attention to this, my dear friends. Thymectomy, thymectomy, thymectomy. Thymectomy is a concept that means if I remove the thymus, the factory of the antibodies, the patient will get rid of the problem? Yes. There has been a multi-center trial done in Europe and they found that post-thymectomy, after thymectomy, around 85%, now look at this brighter figure, 85% of myasthenic patient developed symptom remission. They developed symptom remission. That is 85% of myasthenic patient post thymectomy did not have any ptosis, ophthalmoplegia, anything of this sort. They had total symptom remission seen with them. And approximately 35% of the patients became drug free also. That means post thymectomy, not even a pyridostigmine or any kind of an immunosuppressant was required in these patients. So they became drug free. So look at the concept now. I'm making the patient symptom free and drug free. That is possibly a good thing for him. No, this cannot be anything better than this. So remember this as a recommendation. It goes like this. Thymectomy, it is recommended in all patients. In all patients, in spite of medical control. Now read this line very carefully. I'm giving pyridostigmine to the patient, I'm giving immunosuppressant to the patient, and in spite of medical control, that means there is no crisis, there is no problem, they're responding well, still I go and do thymectomy surgery in them. Okay. Now they found that somewhere conditions apply are there. They found that the most useful indication to do thymectomy. Now tell me, in a myasthenic patient, what should be the most useful indication to do a thymectomy? What should be there in the thymus? That if I remove, I'll get rid of not only myasthenia problem, I'll get rid of another big problem which is more challenging or rather life-threatening to the patient. What is that thing? Thymoma. Good. Thymoma was always a tumor which is a bomb which is ready to explode inside. So if I remove that thing, I'll get rid not only of myasthenia, I'll also get rid of the local compressive effect, or could be a paraneoplastic syndrome which could happen with them. Okay. And now conditions apply, a big question mark comes in now. This very important question mark. In some people, thymectomy with myasthenia, it's all up to me to decide to do or not to do. Now question mark. Less than 15 years, above 55 years. Why less than 15 and above 55 clause? We all found somewhere less than 15 years of age, although I agree myasthenia is very rare in that age group, but still if they get myasthenia and I go and do thymectomy in a peripubertal age, please tell me, thymus is a lymphoid organ. If I remove it in a person who is peripubertal, who has not even reached puberty, what is going to happen next? The very catastrophic thing in the patient's life. I'm removing a lymphoid organ, no? Yes. We are going to have a big problem in people less than 15. A bigger challenge than myasthenia we could face is immunodeficiency. Yes. So less than 15 years of age is always better to wait till the age of 15 and then go for thymectomy, because we found that less than 15 years of age, if we did a thymectomy surgery, it created more trouble and did less benefit. Above 55 now comes in. Is that the problem is the vestigial organ. Now there's a controversy. Now you'll just come back and ask me again. So no, I've read it in physiology. So thymus regresses functionally and anatomically beyond the age of 18 or 20 somewhere. I agree with the thought in path books, but in medicine book they say till the age of 55, it is still workable. It is still workable. It can come back to life, but beyond the age of 55, we found somewhere the thymus never ever worked. It was always seen as a vestigial organ, maybe present but not working. Now look at the concept. When the organ is not working, then there is no point of removing it out. So beyond the age of 55, the organ thymus becomes a vestigial organ. So you can always put a question mark on them. That means that beyond the age of 55, I may not do this kind of a surgery, thymectomy. Another big question mark is this. A patient of myasthenia who is having eye muscles weak only for a duration of 3 years, known as ocular myasthenia. Now, why do we think that the question mark will come for ocular myasthenia? This is all because of the risk. Risk of two things. Doing a surgery, one, or myasthenia gravis itself, a disease. Now please tell me, if you imagine this surgery, thymectomy, we can approach the retrosternal area by laparoscopic approach nowadays, that's good. But still, what is the risk bigger? Myasthenic disease in eye only for 3 years, ocular, or surgery? Which is a bigger risk? Surgery S or the disease D? You can just type that word. Obviously, the risk of surgery is more than the disease anytime. So what happens now is the surgical risk outweighs the disorder risk. So you can just postpone in them. So in ocular myasthenia gravis, you may not go ahead and do a thymectomy because the surgical risk is always more than the disease risk. Then we have this one, mask antibody positive people. In these people, we found that the benefit of the surgery was very poor. Why? Common sense. Is that, the musk antibodies are not formed in the thymus gland. Thymus is a factory for the acetylcholine receptor antibody, not for the musk antibody. Musk antibody comes from some other lymphoid organ. So the point here is, if I remove thymus in a patient who is musk antibody positive, the benefit will be low because the factory of the musk antibody is somewhere else. Simple. So let me put this again. Let me put this all again in a different way. Thymectomy is recommended in all patients in spite of medical control, but conditions apply. What are those conditions? Patient ideally should be between the age of 15 to 55. Less than 15 years of age, you might go into immunodeficient problem. Beyond the age of 55, it becomes a vestigial organ. It is most likely or more likely a patient of generalized myasthenia. So in patients with generalized myasthenia gravis, you go and do a thymectomy surgery. Because in ocular myasthenia gravis, we found that the risk of surgery is obviously more than the disease anytime. And the third indication, or rather the third thing in conditions apply, is this: musk antibody negative patients. So people who are musk antibody negative is something who are really going to be benefiting by this kind of a surgery. So the patient should be musk antibody negative. It should be a case of generalized myasthenia, and the patient should be in a bracket of 15 to 55 years of age. Simple. Now I'll explain all your doubts in a simple flowchart. I'm getting a lot of doubts from your end. Okay. I'll just put this in a very simple flowchart. All your doubts I'll answer in the flowchart. Don't worry. A myasthenic gravis patient comes to me. It could be three kind of people. Either it's a case of ocular myasthenia gravis. Second, it's a case of generalized myasthenia gravis. Again, boxes are coming, sorry. And the third wala is a patient of crisis, myasthenic crisis. So there are three people with me: ocular, generalized, and patients of myasthenic crisis. We know the definition part. Ocular myasthenic means eye muscles involved only for a duration of 3 years. Generalized means all across the body, and crisis means respiratory failure coming in due to respiratory muscle weakness. Okay. Now let me deal with crisis first. Crisis we do IVIG and plasmapheresis. We give our patient intravenous immunoglobulin, or we do a filtration of the blood, giving them a blood plasmapheresis. So for crisis world, IVIG and plasmapheresis are the two standard treatment, or a Sanjeevani booty to save their life. Okay. For ocular and generalized, yes, we go with pyridostigmine as a standard drug. Pyridostigmine. That was always considered to me as a drug of choice. Pyridostigmine. Okay. Now in generalized, after starting pyridostigmine, remember this: always make it a point to evaluate the particular patient of myasthenia gravis for thymectomy surgery. Thymectomy is surgery which is done as a protocol in all patients of myasthenia. Why I want to evaluate the patient for this? Why? Because is the patient fit for this surgery or is the patient unfit for this surgery? That means I'm doing a thymectomy and in the background, in the medical history along with myasthenia, the patient had COPD, some coronary artery disease, some renal problem, something like this. So is the patient fit or unfit? Two things I have to think. Now, if the patient is fit, correct, I will obviously go for thymectomy surgery. Please tell me if the patient is unfit for thymectomy. After pyridostigmine, what should I go and do for the patient? If the patient is unfit for thymectomy, what else can I offer the patient to improve the quality of the life? What is that thing? This is nothing but your immunosuppressants. Immunosuppressants. So remember this, the immunosuppressants are something which are going to boost up the thing, or rather boost down the thing of destruction maybe. Now please remember, even after thymectomy, you advise for immunosuppression. Why? Once you have removed the thymus, the factory of antibody, then what's the role of immunosuppressants? I'll tell you this fact. The acetylcholine receptor antibodies, the acetylcholine receptor antibodies are of the type IgG. So IgG kind of antibodies are these. So these antibodies are IgG type. They are there with me for a very long time. Okay. So if at all old antibodies are there, they can cause a destruction and all that thing. I can easily suppress by giving what? Immunosuppressants. Simple. Now tell me, what about ocular myasthenia gravis? What's your opinion for this? Ocular myasthenia. Should we go and do a thymectomy? No. We might give them immunosuppressants. Now I'm using the word might give them, not necessary. Why? If the patient has got a unsatisfactory response, that is, a patient of myasthenia gravis, I find, is not improving as I expected it to be. If he's getting an unsatisfactory kind of a response, then in that case we think that yes, immunosuppressants are required. Because see, immunosuppressant and all these things that we have with us have got always an additional problem of Cushing syndrome and all these problems. So if there is an unsatisfactory response, then only we go for a immunosuppressant therapy. Student asked me in between also in the beginning, sir, what about bulbar myasthenia gravis? So you do not tell me anything about this separate. See, one thing is very clear. For bulbar myasthenia gravis, you advise them pyridostigmine. One thing, okay, and you advise them immunosuppressant, that is rituximab. So just a name of another immunosuppressant that I did not mention in the list earlier, rituximab could be used in patients of bulbar myasthenia gravis. Okay. Why not plasmapheresis and thymectomy? See, plasmapheresis, IVIG are usually given in crisis phase of myasthenia. Some of the recommendations also do tell me that before doing a thymectomy, you should ideally go and give an IVIG shot and then start doing your thymectomy surgery. Okay. Now there is a cousin brother of myasthenia. Don't forget the name. The name is Lamberton. Lamberton, yeah. Oh, acha. Good. Someone asked me a genuine doubt. I'll come back to this. So you told us thymioma should be there. then only you go and do a thymectomy surgery. Now the doubt coming from the student end is this, sir, if thymoma is there, then only should I go and do a thymectomy surgery? Tell me now. My question for you guys is this. That means a myasthenic patient doesn't have a thymoma. Should I go and do a thymectomy surgery or no? Answer me this, yes or no? Tell me. Patient doesn't have a thymoma and he is a case of myasthenia gravis. You're doing a blunder now. Read it very carefully. Thymoma is the most useful indication, my dear friend, not the only one. If you remember this, 65% of the time the gland was what? Hyperplastic. That hyperplastic gland is also producing what? Antibodies. So please remove it. I repeat, thymoma is not the only indication of doing it. It is the most useful indication of doing a thymectomy surgery. Remember this. It is not the only, it is the most useful. That means even without thymoma, I can go and do a thymectomy surgery in the patient. Okay. Now the cousin brother comes in. The name is Lamberton-Eaton, myasthenic syndrome. A simple and a short topic being abbreviated to me as LEMS. LEMS is a story on the other side. Look at this. This is the nerve for me, okay, and that's the muscle for me. The nerve is synthesizing an acetylcholine molecule inside it, correct? And this acetylcholine molecule is coming out from the nerve on time, and it is happily attaching onto the receptor below on the muscle tissue, correct? But the point here is, to release the acetylcholine from the nerve, we require a cation to enter the nerve, and that cation is nothing but the calcium. So remember this. There are certain calcium ion channels on the nerve present, which have got a name as PQ type of calcium ion channels. So there are PQ type of calcium ion channels which are present on the nerve, which are going to make the calcium enter the nerve tissue. And because of that, there is release of acetylcholine from the nerve. The nerve will get the acetylcholine out from there, which will attach to the muscle on a particular receptor waiting for them. That's a normal thing. Now what's the abnormal thing? The abnormal thing is this. Patient has got a malignancy with him, known as the small cell carcinoma of the lung. So we happen to see a malignancy in the lung tissue, small cell carcinoma of the lung, or the SCC. Now the unfortunate point is this. The small cell carcinoma of the lung, I'm using the word antigenically. Now follow this name, antigenically, resembles the PQ type of calcium ion channels, which are present on the nerve to make the calcium enter the nerve and release the acetylcholine. So there is a molecular mimicry in antigens now. The antigen which was on the lung cancer is same antigen on the PQ type of calcium ion channel. So what will happen now? We know the immune mechanism in our body. Against malignancy, we have also got a fighting capacity. So antibodies which are there against the lung cancer being developed in the patient would come and cross react with the calcium ion channels. So at the end of the day, what do you find? There is a defect created on these calcium ion channels. Now once this defect on the calcium ion channels happen, there is going to be less influx of calcium into the nerve, and as the end result, what could happen in the patient? Decrease in the acetylcholine release. A very simple concept. So there is a decrease in the acetylcholine release which has occurred in these patients. Now when I look at this defect this time, unlike myasthenia, I'm using the word unlike myasthenia, is not on the muscle, it's on the nerve tissue. So this defect is seen to me as a pre-synaptic defect. That means it is present on the nerve, not on the muscle. So this pre-synaptic defect is seen in the patient. A defect on the PQ type of calcium ion channels causing decrease in the acetylcholine release. Now, can you tell me please, uh, who came first in the disease? Lung cancer, SCC, or LEMS? Who came first in the disorder? Who came first? The defect came in first or the lung cancer came in first? Obviously, it's a lung cancer coming in first. That means it is a paraneoplastic syndrome. Look at the name now. There is a malignancy in the lung, and now my neuromuscular junction is getting affected because of this. So we always label this LEMS as a sort of a paraneoplastic syndrome. Smoking came first, I know that. In Delhi, if I live for a few more days, I'll also have a lung cancer because we don't smoke cigarette, we smoke the air over here. But luckily the lockdown has improved only one thing, the air quality. The pollution in Delhi, they say, is so less. Pollution in Delhi nowadays is so less that the orthopedic surgeons can also read ECG. Bad joke. Okay. Now when I look at the clinical features. Now when I look at the clinical features of these patients of LEMS, remember this. Weakness is seen in the patient. Right? Weakness, remember this, in LEMS patient is most commonly seen in the skeletal muscle, followed by the facial muscle, followed by the ocular muscle. So the first muscle group involved, unlike myasthenia in my LEMS patient, is skeletal. See, in myasthenia, if you remember, the order was entirely different. It was ocular first, skeletal last. I put the order reverse over here. Do remember this concept, the deep tendon reflexes that we check. Oh, again a box has come in. The deep tendon reflexes that we check. In these patients, there's either decrease or absent. That means these patients often have got areflexia with them. I'll just come back to this, scrolling up and all this. Don't worry. Bladder. Urinary bladder, a part of the autonomic system now, is found to be involved in them. So there is some autonomic abnormality in myasthenic patients, and bladder is involved in them, with the deep tendon reflexes often getting depressed and absent, and the weakness is more commonly skeletal. Now when I look into the investigation part, remember this, the hydrophonium test that you do in these patients, remember this, the hydrophonium test that you do in these patients is also found to be positive. Now I'm using the word also found to be positive. Like in myasthenic patient, it was positive, but in LEMS also it is positive. Why? I'll explain this why. Like for example, I'll come back to this diagram, the very first that we are trying to see again, LEMS. The acetylcholine has come out from the nerve, but in LEMS, there were antibody against the channel calcium, stopping the efflux of acetylcholine. That was a basic concept now. Now just imagine, by chance, I'm using the word by chance, there are one molecule of acetylcholine there in the cleft. By chance, there is one acetylcholine molecule in the cleft. Now there is an enzyme which is going to come and eat it away. The name is acetylcholine esterase. What do? I inhibit this enzyme by giving one drug which is known as your hydrophonium. Correct? What will happen? The acetylcholine level will rise now. If the acetylcholine level by chance rises, will this molecule of acetylcholine work only on one receptor? No, it will act on at least 4 receptors. Now follow this out. I agree. There is very lesser amount of acetylcholine there in the cleft by chance. If 1 or 2 molecules are there and I inhibit the degradation of these molecules by giving an hydrophonium injectable, one molecule will not act on one, it will act on 2-3 receptors, and the weakness will start improving in them also. But now conditions apply. The hydrophonium that we find positive in them is found to be weakly positive. Remember this. So it's not as strongly as a myasthenic patient could come out with. That means within 5 or seconds, or maybe in a span of 1 or 2 minutes, we find the weakness to improve in them. In these patients, the weakness improves comparatively slowly and less in that amount. Okay. I'll show you this diagram. I've got an image with me. Oh, Trump is back. Yeah. The madam from T series is also back. Okay. She was having ptosis. She was happening to make herself smile. She had that snarling appearance. She got edrophonium. 2 plus 8, that equates to 10 mg. And her ptosis improved. And her smile came back. So what the boyfriend could not do, edrophonium could do very well on her. That is a rationale of the tensilon test anytime. So remember this, tensilon test in a myasthenia gravis patient. Now, whosoever made this meme, I remember this, it came 1 year back. In myasthenia gravis patient, yes, would improve so well within few seconds. Okay. So, but in LEMS patient, the weakness is not that much better as we found in myasthenic. It's weakly improving. Okay. Now remember this, rapid nerve stimulation or RNS. Rapid nerve stimulation that we do in these patients, the action potential in the muscle. Now, they found like this: first, second, third. Okay, I'll make it again. Sorry, just rub this out. First, second, and the third stimulation that I give to the nerve, the action potential that I find in the muscle is low. But the fourth and the fifth, the action potential seem to improve by a minimum magnitude of 10%. So look at this now. As I keep on stimulating the nerve, now this time please write this down. Stimulation at higher frequency. Stimulation at higher frequency, that is somewhere taken as 50 Hertz in these patients. So in LEMS patient, we stimulate the nerve at a higher frequency, or higher frequency of 50 Hertz. And now we find in the muscle, the action potential starts improving. Now, can you tell me the name of this kind of a response? Yeah, good. Someone has already answered it. It's known as the incremental response. Now, I know you have a query in your mind that, sir, why does it happen? Why does it happen? Don't go into the why thing, because even I could not find a good satisfactory answer for it. But they somewhere told like this. My professors told me, sir, there are PQ type of calcium ion channels which are still working, but not affected by the antibodies. Maybe a higher stimulation of 50 Hertz would make them work. So if someone is not studying, if I keep on stimulating that person, you have to study. Suddenly next day the person will start studying. That is an incremental response in him. So just imagine with that simply, it's enough. Okay. Now the treatment. As a treatment part is this: 3-diaminopyridine. There are few more drugs which have come in the market recently, but just remember this name, because in Harrison they just mentioned till date this one: 3-DAP, 3-diaminopyridine. It increases acetylcholine release from the nerve. Correct? It increases the acetylcholine release from the nerve. Remember this. So 3-DAP is considered to be a drug to improve the weakness in this patient by increasing the acetylcholine release from the nerve. Rapid nerve stimulation will always show an incremental response in these patients. Edrophonium is always weakly positive. Autonomic, like bladder is involved, reflexes are depressed. Weakness is first skeletal, last ocular. It's a pre-synaptic defect, and a small cell carcinoma of the lung is the malignancy which is very commonly associated in these patients. Okay. Now let's see. If you want to read more, it's fine, but इतने भारी ज्ञान की जरूरत नहीं है. Okay. Too much is bad always. Now tell me something which I don't know. सांग मला जो मला माहित नहीं. Okay, that's an important dialogue. Tell me something which I don't know. Are the MCQs that I have got with you with me. So you'll try to solve some MCQs on this topic and tell me something which I don't know. Okay. What are those MCQs? Right. Which of the following nerve is least commonly affected in myasthenia gravis? Now answer please. Which of the following nerve is least commonly associated in myasthenia gravis? Cranial nerve, these are the cranial nerves. The 3rd, 9th, the 10th and the 12th cranial nerve. Any ideas? I'll give you the idea on this because your guidebooks, I've seen them, they have written the answer very cleverly over there. Still searching. Still searching. And now I went to a library one day to find the answer for this question. I searched every journal article, every book, and my answer after one day of search was still there, still searching. And now what happened is, one of the students saw me from a distance and asked me, sir, what question are you searching? I said, this question. He looked at me and said, sir, this is a very easy question. You don't know the answer. I said, no. So why don't you know the answer? You are a teacher, you should know every answer, sir. I said, leave sarcasm, tell me the answer please first. Now that boy answered me very nicely on this topic. The 3rd cranial nerve, oculomotor nerve, is for moving the ocular muscle. So when I write the word M, it's a motor nerve actually. So 3rd oculomotor nerve is a motor nerve, which is moving the eyeball and keeping the eyelid open, everything. 10th cranial nerve is again a motor nerve. Yes. And it is supposed to supply the pharynx for the process of deglutination. Correct. 12th cranial nerve is again a motor nerve, which is going to supply the tongue muscles for movement and articulation of speech. But the 9th cranial nerve, remember this, is going to give me a taste, yes, from the posterior 1/3 of the tongue. So the posterior 1/3 of the tongue, the taste signal is going to come from there. And also the 9th cranial nerve is going to supply me the pharyngeal muscle. So if the pharyngeal muscles have got to get a sensory supply, it comes from the 9th cranial nerve. That means the 9th cranial nerve basically behaves as a sensory nerve in action. I agree with your thought. There is one muscle which is supplied by the 9th cranial nerve. I agree with you. But that's only one muscle. The major part it tries to perform is a sensory nerve. Now I remind you, if you remember, the sensory system was found to be normal in patients of myasthenia gravis. Correct? So any nerve which is trying to perform an activity of a sensory nerve, predominantly, I'm using the word now, predominantly will be unaffected in this disease. So read the question. Function of which of the following cranial nerve is least involved in myasthenia gravis? Obviously a sensory cranial nerve, that is the 9th. There are a lot of thoughts in your mind. I know people do answer me later on 10th. I ask them why. They tell me, sir, 10th is deriving its supply from the autonomic plexus also. Correct? I agree with your thought. But the problem is that if the 10th is not involved in myasthenia, why would a bulbar myasthenia kind of a disease happen? That means there was never a difficulty of solving. So 10th, the motor function onto the skeletal muscle is commonly involved in that. Okay. Why is 3-diaminopyridine not used in myasthenia gravis? Oh God. See, the release of acetylcholine from the nerve is perfectly normal in myasthenia. So there is no problem in the release part. 3-DAP is a drug which will often increase the release of acetylcholine from the nerve. In myasthenia gravis, there is no problem at that time. The problem is that the receptor is not able to get the proper amount of acetylcholine because they are either dead or blocked. Okay. 21-year-old female with a history of bilateral ptosis, proximal muscle weakness and easy fatigue. Which of the following is best in diagnosing her condition? First of all, look at the question again. A female 21 years old has got bilateral ptosis, proximal muscle weakness and easy fatigue. She has got weakness, easy fatigue in the proximal muscle with eye muscle involvement, correct? Should I go and do muscle biopsy? Never. Because in this condition, I always suspect myasthenia gravis. So I'm not suspecting myopathy. So there's no point in doing muscle biopsy. Yes, you are answering it right. EMG is another trap that I won't fall into because EMG will not record the jitter so well. It's an SF EMG now. Hydrophonium versus RNS, I clarified this earlier. When I look at the sensitivity specificity data somewhere, hydrophonium is considered to be slightly better than RNS. So, correct. So the nation knows it, the correct answer. 50-year-old male, now this is a big question, presents with complaints of ptosis, difficulty in chewing, occasional difficulty in swallowing. There is no history of diplopia or visual loss. On examination, there is a asymmetrical ptosis with mild restriction of the extraocular muscle with a finger abduction test. That means we tell the patient to look at our finger and patient cannot follow the finger so well. So there is some kind of ophthalmoplegia, yes. RNS shows a decremental response in the orbicularis muscle. Now the trap again comes in. EMG revealed a myopathic pattern. I'll come to that concept also. And anti-acetylcholine receptor radioimmunoassay is negative. Your antibodies are negative. RNS shows an decremental response. I don't know, EMG revealed a myopathic pattern. Patient has got ocular and not only ocular, swallowing, pharyngeal muscle weakness, facial muscle weakness, chewing. Correct. When this question came for the first time, I'll tell you, students very proudly marked the answer as C. Great consultants we have got. As acetylcholine receptor radioimmunoassay is negative, you will consider for an alternative diagnosis. Hi, what is this? Incorrect answer. Because negative antibody does not exclude out myasthenia gravis. Remember my words. Now it's very clear from the discussion, it's a case of myasthenia. Now the problem is to quantify or qualify it as ocular or generalized. Look at the symptom. It is eye, it is pharynx, it is face. Well, what do we do? Yes, it's not only in the eye, it's also seen on the whole body. If I look at beyond the eye, the pharynx and the facial muscle could be involved. So the answer has to be generalized myasthenia gravis. That's a better answer. Now I clarify this now. EMG revealed a myopathic pattern. Even when I read this as a recall, I was very surprised. What are they trying to tell me? Later on in the higher books, I could read that EMG sometimes in myasthenic patient can show a myopathic pattern. That's why every time we advise for a SF EMG, not the routine EMG. Okay. So the nation knows it. Fine. Now people who are slightly more confused in the thymectomy kind of a drama, let me show this question now. Question number 4. In myasthenia gravis, correct statement for thymectomy is should be done in all cases. That's true. Because irrespective of medical control, we go and do it. Should be done in cases with ocular involvement only. Now read it carefully. Ocular involvement, we can just wait and watch because the risk of the surgery is more than the disease anytime. Now look at option C. Not required if controlled by medical management. Now this is a paradoxically incorrect statement. Why? Because myasthenia gravis patient, it is done in spite of medical control. Okay, so it's paradoxically incorrect statement. Should be done in patients with associated thymoma. That's also correct. Now there are two correct answers in front of me, A or D. Yeah, let me see what the nation knows. Let's start the debate with a hot topic. The hashtag is thymectomy now. Should be done in all cases. Should be done in patients with associated thymoma. What should I do? See, the all cases means everyone. My dear friend, if you are answering it A, read it again. All cases means everyone. A person whose age is less than 15, above 55, pure ocular, musk antibody. A means everyone. So what should I mark now? It's a blanket kind of thing given to all cases now. If the option A is there like this, don't hesitate to mark it as D. That's better and more appropriate answer. Should be done in patients with associated thymoma. Yes, it's more correct than option A now. Okay? Rhythm correct. Now read this question number 5. In myasthenia gravis, correct statement for thymectomy is same question with a different answer and a different version. Should be done in all cases. Should be done in cases with ocular involvement only. Wrong. Should not require if controlled by medical management. Not. Should be done in patients only with associated thymoma. Now answer me. Question number 5. I'm question number 5. What is your better answer? A or D this time? I repeat my words. Thymoma is the most useful indication, not the only indication to be done. Thymectomy. I repeat. Thymoma is the most useful indication, not the only indication. So what should I answer in this case? Which is a safer answer, A or D? A is safer than D. Okay? Good. The nation knows it now. Now look at this question. Another interesting one. A 30-year-old female patient has come to me with facial and ocular weakness and has been diagnosed with myasthenia gravis. You intend to initiate therapy with anticholinesterase medication, that is pyridostigmine and glucocorticoid, that is an immunosuppressant. All of the following tests are necessary before instituting this therapy except. What should I do in a patient before starting this therapy except? That means what investigation or maybe what kind of thing I should not be doing in the patient. MRI mediastinum, yes, I do it because I want to see a thymoma, and if it's there I want to operate on it as early as possible. TSH levels also I do it. If you remember, 3 to 7% were hyperthyroid, so get it done also. There's no harm in it. Tuberculin test, yes, I do it. Now what's the relevance? Now the relevance is that once I put the patient on a glucocorticoid, which is an immunosuppressant, something in the body quite occult might just flare up. That is nothing but my national disease. National disease, not COVID, it's TB. And TB can be easily found out in a latent phase by a tuberculin test. If that's positive, I may not give all these immunosuppressants for the time being. What are we left with? LP, lumbar puncture? No. LP doesn't help me to prognosticate the patient, other diagnose anything else. So that's totally out of syllabus for this patient. So LP is not the test that I'll do before starting a pyridostigmine or glucocorticoid therapy in such a patient. Simple answer. Now that's a big one, but an easy question and an easy answer. 45-year-old male presents with 2 hours history of progressive weakness and severe dry mouth. 2-year history of progressive weakness and severe dry mouth. On physical examination, he has got bilateral proximal arm and leg weak along with absent reflexes. Now there is a proximal muscle weakness with a areflexic kind of a thing occurring in the patient. After repeated testing of quadriceps, his strengths improve and the patellar reflex appear. That means we keep on testing the thigh muscles and suddenly the strength which was there starts improving, and the reflex which was absent, that is a knee jerk, also appeared in the patient. Now the nerve conduction study, sensory responses, everything is fine. That means the peripheral nerve is working okay and fine. That means the nerve inside the whole apparatus is perfect. But the rapid nerve stimulation that we do at 50 Hz, that is a higher frequency, shows me a graph like this which starts improving. Incremental response. You know the answer is good, but you should know every option. Which of the following is true about the condition? Post-synaptic MuSK antibodies are present. That's present in myasthenia gravis. This is a case of LEMS which I am clearly seeing. So that's not the correct answer. This disorder is associated with colon malignancy. No. They are most commonly associated with small cell carcinoma of the lung. I agree, there can be some incidental findings of this with that, but the examiner is using this word commonly associated. No. Not commonly with colon, commonly with small cell carcinoma of the lung. Spores of honey are responsible for this condition. Now can you tell me what is this honey doing over here? Sweet thing honey? Yeah. What is the relevance of honey in this case? Can you tell me now? There is a poisoning which we have documented very often in children, neonates, infants, which is coming from the honey source. What is that poisoning which can be happening and can cause a neuromuscular weakness in the patient? Yeah, good. Botulinism can easily happen through honey feeding. I'll tell you the concept. Like in India, if a child is born, the mother starts feeding the child with the breast milk. But in the background, the grandmother from paternal and the maternal side, the dadi and the nani comes in and tells the mother, no, the first thing as a ritual we should always give is honey to the kid. And that is from the Patanjali. Yeah, Patanjali products are prasads. Everyone should eat it and die also. Now the child feeds on the honey, and we found the child suddenly in the ward gasping. We could not know what's happening. And we went out and took the history. Initially, he has got the weakness in the facial part, and then the weakness progressed very fast. So that is a botulism poisoning or botulism toxin, which will come from the spores of honey, which is there. Okay. They can also, how does a botulism toxin work? If you remember this concept, if this is the nerve, yes, correct. This is something which will inhibit. The botulism toxin will inhibit the release of acetylcholine molecule. So the acetylcholine molecule that was supposed to come out from the nerve could be inhibited by a botulism toxin. Simple. Another thing I remember could inhibit the acetylcholine release from the nerve. Can you tell me that thing? One more poison. One more poison could inhibit the release of acetylcholine from the nerve. Rather, one or two more toxins. Okay, two more toxins with me. Good. If you know it's very good. Something, yeah. One is snake bite, snake venom. If you remember, the snake venom is also something which can cause neuroparalytic snake bite by inhibiting the acetylcholine release from the nerve. One more toxin. I'm not getting the correct answer. Yeah, someone answered me correct. Curare toxin. Curare toxin. Long back when the Raja Maharaja, the kings used to go for hunting. Yes. And they saw a deer in the forest. They used to hit the deer with an arrow. And the arrow was having a curare poison on top of it. That means whenever the arrow hits the deer paralyzes and dies. So they can come and eat the deer later on. But in the modern world, if some actor goes to a forest, he kills the deer over there. The deer dies of angina pectoris, natural causes. Kalyug. Bad joke. Some Bhai ke fans must be angry with this joke. Sorry. Now we got the answer. That is pre-synaptic voltage gated calcium channel antibodies are present in the patient. Okay. Right. That's a song which I saw yesterday. Shaniwar Rati. Mujhe neend nahi aati. And I thought that people who don't understand Hindi could not understand. So it's known as Saturday night insomnia, and it's Saturday night. Okay. Any doubts? Most welcome. Happy to share with me. On the Facebook club, I'll be putting a post very soon. Okay. So it's Saturday night. Party time. Okay. Ramayan is over. Sorry. Tomorrow again we are going to meet at 7:30 p.m. See, it's a Ramzan time. We have to take care of our friends also, because whole day they are fasting, and if iftar somewhere happens at 7:15, they can have something and come for the class. That's good. Okay. Tomorrow I'll take out some topic like CNS infections. It is a theoretical topic actually, but it's a high yield topic because we get a lot of questions on CNS infections. Okay, and it's a variable topic covered here and there also. No, tomorrow is not a holiday, please. We in dance work on Saturday and Sundays most of the time. We have to go from Delhi outside to every city to take a class. I still remember my kid in the school very proudly told his class teacher that my dad goes to his office in a aeroplane. And then his class teacher asked me, sir, are you working in airport or some airlines? I said, no, madam. I fly every Saturday morning or Friday night. And there's an office every part in the country which we have. Okay. Tomorrow again at 7:30, I'll announce in the club again. Okay. Oh my God, your doubts, queries are multiplying. Good night. Stay home, stay safe. Okay. Bye. I'll answer all your doubts on the Facebook club.